Good afternoon, teachers and friends. I am Shahbaaz Ahmed as a urology first year resident from Medical College, Kolkata. Today my topic of discussion is adrenalectomy. History. John Knowsley Thornton is credited with the first successful adrenal surgery in 1889. This is a picture of him which was published in an article in 1904 after his death. The interesting thing about it is that he was unaware that it was an adrenal tumor. He took it out as an abdominal tumor en bloc with the left kidney. Sargent in 1914 is credited with the first planned adrenalectomy via a T-shaped subcostal incision. Charles Mayo performed the first flank adrenalectomy in 1927, and Broster performed the first transpleural transdiaphragmatic approach to adrenalectomy, which provided excellent access to large adrenal tumors which were operable. Now, beginning of an era. Dr. Gagner performed the first laparoscopic transperitoneal adrenalectomy in 1991. Mersan in 1995 performed the first case of retroperitonioscopic adrenalectomy. And Piazza et al. And Hubens et al. In 1999 reported the first robot-assisted laparoscopic adrenalectomies. Now, the relevant anatomy of the adrenal glands. The venous drainage of the adrenal glands is more predictable, whereas the arterial supply is variable. The right adrenal vein drains into the IVC and the left adrenal drains into the left renal vein. The arterial supply is from the superior, middle and inferior adrenal arteries, which are derived from the inferior phrenic, abdominal aorta and renal arteries respectively. The functional evaluation which will be done for all adrenal tumors. Glucocorticoid excess to rule out Cushing syndrome. Low dose dexamethasone suppression test should be done. ACTH should be done. Catecholamine excess to rule out pheochromocytoma. Serum or urinary metanephrine should be done. And mineralocorticoid excess for Conn syndrome. Aldosterone to renin ratio should be done, but only in patients with hypertension or hypokalemia. Now, this is the management algorithm for newly diagnosed incidental adrenal masses of more than 1 centimeters. 3 features are taken into account: the imaging features, the size, and the metabolic workup. We can see over here that lipid-rich tumors are considered benign, whereas lipid-poor tumors are considered indeterminate. This is based upon the Hounsfield units on CT scan. The size cutoff is 4 centimeters. The metabolic workup is based upon serum cortisol levels, metanephrine levels, and serum aldosterone levels. Now, no further follow-up of the patient is required if the tumor is considered benign with a size of less than 4 centimeters and is metabolically silent. Follow-up of the patient is required if the tumor is indeterminate or the size is more than 4 centimeters or it has autonomous cortisol secretion. Now, adrenalectomy is considered if the mass grows by more than 20% or at least 5 millimeters or becomes metabolically active. Adrenalectomy can also be considered if the tumor is indeterminate with a size of more than 4 centimeters. Now, the surgical indications for adrenalectomy, they can be broadly divided into functional tumors, non-functioning tumors, size criteria, radiological imaging criteria, and the METs. So, functioning adrenal masses include aldosterone secreting adenomas, cortisol secreting adenomas, Cushing's disease, which is unsuccessfully managed by transsphenoidal surgery, and pheochromocytomas. Non-functional tumors include histologically confirmed adrenal cortical carcinoma, symptomatic adrenal masses such as cyst and myelolipomas, adrenal incidentalomas. The size criteria: incidentaloma more than 6 centimeters should be operated because there is 25% chances of malignancy. Incidentaloma between 4 and 6 centimeters, there are 6% chances of malignancy with increases with suspicious features such as irregular margins and heterogeneous enhancement. In incidentoma less than 4 centimeters, the chances of malignancy is just 2%. So only if it enlarges by more than 20% or at least 5 millimeters, then we should consider surgery. Solitary adrenal mets from a non-adrenal primary is also an indication. The radiological imaging criteria: more than 10 Hounsfield units in an unenhanced CT scan, enhancement washout of less than 50%, and delayed attenuation of more than 35 Hounsfield units on contrast.
It's a case presentation we are waiting. We should inform him.
These things should be told later on. Initially, you have to present your case, then you can give some literature backup. Literature backup to be given after presenting the case. You just present your case first, then you can give the literature.
Okay, sir. So, case 1, a 21-year-old female presented with chief complaints of heaviness in the right hypochondrium since the last 3 months. On examination, the general survey was normal. She was not hypertensive. Abdomen was soft and no lump was palpable. On imaging, ultrasonography showed a 5 centimeter SOL in the right suprarenal region. The CT scan showed an adrenal SOL which was hypodense, well circumscribed, heterogeneous mass with an attenuation value of minus 90 Hounsfield units. Now the operation was done in the open operation was done supine with a body roll placed under the back. The position incision was right subcostal. The approach was anterior transabdominal. The steps of surgery: the hepatic flexor was mobilized inferiorly, the liver was retracted superiorly. Cocker's maneuver was done to mobilize the second part of the duodenum, and the IVC was exposed. Careful dissection and ligation of the right adrenal vein was done, and the specimen was extracted. Now this is the original picture of the operation. This was the adrenal vein and the draining into the IVC. Here we can see that the right adrenal vein takes a very short course to enter the posterolateral segment of the IVC. This was the picture of the specimen, the intact specimen of the adrenal tumor, which measured around 6 centimeters. Now the post-operative management: the patient was nil per mouth for 1 day on IV fluids. On POD1, sips of water was allowed, followed by liquid diet. On POD2, normal diet was allowed as IPS was normal, flatus was passed, and drain was omitted. Wound care was done and chest physiotherapy was given. The patient was discharged on POD7. The second case was of a 34-year-old female presenting with chief complaints of pain in the right hypochondrium for the last 6 months. On examination, the general cervical was absolutely normal, and there was no lump palpable on abdominal examination. Ultrasonography showed a 7.8 centimeter into 7.1 into 4.3 centimeter SOL in the right suprarenal region with internal calcification. The CT whole abdomen revealed 6 into 5.1 centimeter SOL in the right suprarenal region without any enhancement. The operation was done laparoscopically. In the left lateral position, 4 ports were introduced. The approach was transabdominal. Now liver retraction was done. The dissection part was similar to the open procedure, and specimen extraction was done. Now the post-op recovery of the patient, and she was kept 10 p.m. on day 0. On POD1, sips of water followed by liquid diet was given. On POD2, semi-solid to normal diet was allowed and drain omit was done. The patient was discharged on POD3 because she was doing very well. On comparison of the two surgeries, open versus laparoscopic, we found that the advantages of laparoscopic were there was much less post-operative pain because of the wounds. Early mobilization of the patient was possible and early discharge was planned. The disadvantages were that it was very technically demanding and it took a longer duration. Now, these are some of the studies which have compared laparoscopic with open adrenalectomy. This was a study conducted in Belfast Royal Victoria Hospital. Laparoscopic adrenalectomy versus open adrenalectomy from a retrospective comparative study. The conclusion they drew was that the patients who underwent laparoscopic adrenalectomy had a significantly shorter hospital stay and experienced significantly less post-operative morbidity than those who had an open operation, but the operation time was significantly longer for the laparoscopic group of patients. Study in Beijing, open adrenalectomy versus lap adrenalectomy for adenocortical carcinoma stage 1, 2, 3. A retrospective comparative study on short-term oncological prognosis. In their study, all the patients who were operated laparoscopically had shown local tumor recurrence. So they drew the conclusion that open adrenalectomy is superior to lap approach in terms of disease-free survival and the rate of 2-year disease-free survival, in spite of the larger maximum diameter of tumors and lesser benefit during peri-operation. After laparoscopic adrenalectomy, patients are more likely to show local recurrent lesions at the first time of relapse. And in a study conducted in Qatar, a descriptive comparative analysis of the surgical management of adrenal tumors, the open, robotic, and laparoscopic approaches, they drew the conclusion that robotic adrenalectomy could be a safe and effective surgical approach for patients with benign functioning adrenal tumors of a diameter less than 6 centimeters. However, the choice of the surgical approach varies according to the experience of the surgeon and the characteristics of the tumor. Open surgery is considered the first choice for larger ruptured adrenal tumor or malignancy. So these were the cases.
Okay, thank you. Any question from the floor?
So I wanted to show one. This was a picture of Dr. Randeep Wadhawan, the director of pediatric surgery at Fortis Hospital, Vasant Kunj, who took out the so-called world's largest adrenal tumor, weighing around 11.5 kgs.
Okay.
Anyway, are you present with any of the surgeries?
Yes, sir. I was present in the open and the lap one, sir.
Which is the safest way to approach the adrenal vein? In adrenal vein, that is the, you said that is very technically demanding because it is short, it is very difficult to get it. What is the safest way to reach the adrenal vein?
So first we have to put the lateral border of the IVC should be seen carefully, and careful dissection of the lateral border of the IVC we can reach the adrenal vein. And the lower pole of the kidney, the lateral border of the IVC and the adrenal should be visualized.
Upper pole of the kidney.
Sorry, sir, upper pole of the
Pole of the
kidney.
kidney,
Yes, sir.
lateral border of the IVC, and then above.
So the adrenal adrenal glands.
You are dissecting
Yes, sir.
of the lateral border of the IVC, inferiorly upper pole of the kidney,
Yes, sir.
above. Now where is the vein? Vein comes from right side. Vein comes from
So posterolateral aspect of the IVC.
what is
Drains.
its exact position? Exact position of the right adrenal vein, where it is? In lower pole of the adrenal, upper pole of the adrenal, medial side, where? So then you have to be careful when you are dissecting. For approach, you have to know the exact position. Then you can approach only. So it is accepted that you have to dissect over the lateral border of the inferior vena cava.
Yes, sir.
Then you have to go upwards. It is usually in the upper pole, towards the upper pole.
Upper pole of
Very
the
short.
adrenal.
Any question from any?
If nobody asks you, by chance there is avulsion of the adrenal vein, how will you manage it? One minute.
Both
time.
open and laparoscopic.
Both, any way, which
Okay,
is
open.
a very
You tell open.
pertinent emergency or complication can happen for this surgery. How will you manage it?
During
So-
open surgery, you have injured the adrenal vein right side. How will you manage?
So as it lies on posterolateral to the IVC, we have to rotate the IVC and we have to mobilize the IVC and then control the origin of the drainage of the adrenal vein.
That is a good answer. Any PGT would like to give a good answer? Any of the PGTs? How will you control bleeding from the right adrenal vein if it is avulsed accidentally? During open surgery. Any of the PGTs can give an answer?
Step by step.
You can try it. There's no discredit. Yeah, just try.
Sir, at the origin of the adrenal vein, we can put a clamp over the IVC, lateral border of the IVC, and suture it over the rolling.
You must have seen that the rescue stitches and other things are always prepared for laparoscopic surgery.
Then you will ask what is the how
Yeah.
prepared
But you know, once you have clamped it blindly, you cannot repair it so easily. We have to make the IVC free. Then only you can turn it laterally, the IVC, then only you can repair it. Anyway, nice.
What is one danger of an avulsed adrenal vein in laparoscopic surgery? It is a chance of air embolism. So you will need to put the patient head down, inform the anesthetist.
Any role of, see, you do partial nephrectomy, so is there any role of partial adrenalectomy?
Yes, it is
And
indicated.
what tumors will you suggest going for partial adrenalectomy?
Sorry, sir, what?
What histopathological tumors would you go for a partial adrenalectomy, or what clinical conditions you will go for a partial adrenalectomy?
Partial adrenalectomy is indicated in bilateral adrenal hyperplasia, in Men's syndrome, familial bilateral adrenal hyperplasia.
Is there any role of angioembolization in adrenal malignancies or per se large adrenal mass?
Side.
What about angioembolization?
Angioembolization.
Okay, thank you. We can stop.